You get it in, because that's also tough.
Please do that. I ask always.
So welcome to the next episode of Endoscopy Essentials. We are in the middle of hepaticogastrostomy guided by EUS with the world champion Takao Itoi. Welcome back.
Thank you so much.
And we have explained everything already about indications and selections of puncture site, which needle. But now we are actually doing the puncture. And how do you do it? Do you progress slowly till you reach the bile duct, or do you puncture and pull back?
Yeah, I love basically slow the puncturing. Of course, in case of the hard bile duct, like chronic cholangitis cases, in such cases, slow and mix finally the bile duct fast puncture. Yeah, otherwise sometimes difficult to puncture.
So actually you go into the liver, if it's not too hard, slow until you reach the bile duct, right? Like this. But if this is hard, then you puncture. And how do you avoid getting too deep? Or maybe it's not possible and then you pull back and see.
So in case of the hard bile duct, sometimes the so-called the Selzinger technique. So no choice sometimes. But in such cases, maybe no problem. But so if possible, the slow, so no traumatic in the opposite side is much better. Otherwise, Guidewire easily go into the opposite side.
And this may also be a rethinking for the person who is used to do puncturing for tissue, because there it doesn't matter so much.
Yeah.
But here it's very important, right? Slow approach to the bile duct and then hit it. And do you have the needle preloaded with contrast?
It's very important thing. Always preloaded contrast. Yes.
And once
usually so no aspiration of bile.
No aspiration, but when you have the feeling and you see you are in, then you do a little bit of injection.
Exactly.
And if nothing comes, then you modify the position of the needle.
Yeah.
Which might be difficult in small ducts, but that's experience. Huh?
Yeah. So in case of a small duct, in such cases, rather we take care of the contrast injection slowly, and so cannot aspirate the bile, only slightly pushing the syringe, and so see a bubble and ultrasound imaging, and both at that time simultaneously the fluoroscopic imaging.
So it's X-ray and ultrasound in the difficult cases. Okay, so you have visualized the bile duct. Now comes the big question. The main topic here is Guidewire selection and how you get it in, because that's also tough. You know, needle and Guidewire are not always friends.
Yeah. Thank you. So let's go. The next topic is Guidewire selection and manipulation. So which Guidewire is best? I think three factors. There are three factors. One is a minimum friction to needle. That's why if possible, 0 to 5-inch Guidewire. Of course, 19 gauge includes the 0.35 up to 0.35, but the larger diameter Guidewire easily kinking or sealing. That's why minimum friction, but hardness is very important to be able to deliver devices into the targeted area. And so another factor is seeking ability. That's why we love the 0 to 5-inch Guidewire and hard Guidewire and the angle tip.
With a soft tip?
Yes.
Short soft tip?
Short soft is much better. That's why this is a very, I guess, very popular in the world. Yes. Of course, not only the 19 gauge, but 22 gauge needle. Is almost all cases we use the 0.18 inch guide wire at that time, so very limited nowadays. That's why so we use usually the 0.18 and the relatively steep type guide wire.
There are quite some challenges for a guide wire. It should be small and stiff, which is sometimes difficult. But the important message is if you have a larger bile duct, more than 2 millimeters, as we said in the previous episode, and you use your 19 gauge needle, don't go with a 35. It's possible, but it's not good because there's too much friction. So it's 19 gauge and 25 G guide wire, right?
You're right.
Like the VisiGlide here, you have an example.
Yeah.
Okay.
Okay. So let's go the guide wire technique, manipulation technique. So do you have the physician control or assistant control, technician control?
It depends on the assistant.
Yeah.
If I have some of our assistants are more experienced than me, so I prefer them to do. And if not so much, I may interfere and do it by myself.
Similar.
Yeah.
Similar, the physician control guide wire, if we have a good technician, assistant, no need. So please do that. I ask always. So sometimes it's very difficult. In case of 22 gauge needle on the 0.18 inch guide wire, very sensitive. That's why. So at that time, so we love the physician control.
But let's go one step back. So you have injected contrast. So the needle is full of contrast.
Yeah.
Don't you have to flush it with saline a little bit?
Yes, saline.
For the guide wire?
Yeah, yes. Exactly. Yeah.
So you flush it and then you introduce your guide wire?
Yeah.
And what's the most difficult part? To find the bile duct with a flexible tip that you go the right way? Or you are in but finding the way?
Yeah.
So what is more difficult?
Yeah. And
maybe both.
Both difficult. In particular, in case of the, I think both difficult, but so introduce the bile duct is very difficult. Sometimes it's a very important point. Of course, after that, so maybe into the CBD or only higher portion, no problem. So exchange the devices and we can go deeper portion.
Yeah. But the primary entry, but you with your needle, you also have a part. You know, if the guide wire gets stuck, what do? You pull back a little bit, or you go further in, or because then the visibility is often not so good anymore, and that's the toughest point.
Exactly. Yeah. It depends. Sometimes the needle slightly back in the liver parenchyma, and so again negotiate the guide wire.
Very softly, huh?
Very soft.
Yeah.
Otherwise, so this is a video. So you can see, so this is a 0.18 inch guide wire. Very difficult cases, that's why I control the guide wire. Soften the back. This is a common style, but so 19 gauge needle plus 0.25 inch guide wire, usually so my junior working well. Yeah. And so second guide wire technique is very important. Everyone says, always says, maintain the longitudinal guide wire imaging, trace the same imaging. And the ultrasound imaging is a very important point. Otherwise, easily the direction
you get into a different plane.
Yeah. So sometimes we ask somebody to hold the scope.
And follow the image, follow the guide wire on the image.
Keep the guide wire longitudinal imaging. Otherwise, easily slipping or sometimes pushing or back, and so lose guide wire imaging.
But again, it's a combination of EUS and also X-ray.
Both.
Both, yes.
So it is a very important point. So firstly, the puncture and injection And at that time, we take a picture, fluoroscopic picture. So this is a first step of this procedure. And if the wrong scope way or wrong guide wire the manipulation at that time, so we have to take look back the first puncture site imaging, not only ultrasound but also the fluoroscopic, and so adjust the first scope position
to get it back and also see where the bile duct is running.
Yeah.
Because at that time the contrast may have gone away or diluted, and so very important message.
Yeah.
Okay.
Okay, so these two technique is one of key point.
So we discussed the manipulation to reach the bile duct, and then you are in the bile duct, and you getting your guide wire into the bile duct, but you don't get where you need. And then comes the next important decision, because there's still, even if you have your 19 gauge needle and 25 guide wire, there's still friction, right? So don't manipulate the guide wire too long through the needle. Is that the message?
Yes, it is very important.
So then the next step comes, dilate and get a better access, and then you can better work with your guide wire, right?
Yeah, right.
Okay, so the next step is dilator selection for tract dilatation.
Yes.
Yes.
Okay, let's go to the next.
But you have your guide wire some distance in, like 5 centimeters or so. You're a little bit in the bile duct.
Yeah.
So you go as far as you can, even if it's from left to right. Is that?
Yeah.
So you have to anchor the guide wire adequately. And
as long as possible
yes.
in the bile duct.
And then so go in as long, but don't manipulate too much.
Yes.
Okay.
Exactly.
Good point. Thank you.
So let's see the devices for the tract dilation. Nowadays, there are a lot of the tract dilation devices. As you can see, there's divided into 3 types: mechanical dilator, dilating balloon, and electrical cautery dilator. So, firstly, I love the mechanical dilator because non-traumatic, traumatic, and very nice, so perpendicular or the torqueability. So that's why I love the mechanical dilator.
Which is your primary choice?
Yeah.
Which are the exceptions? So when, for example, the liver was very hard, are there instances where you foresee that the dilator alone will not be sufficient and you have to burn your way in, or how do you stratify?
It's a good question. I think, of course, if we know the very hard parenchyma or liver in advance, at that time, so sometimes we need from the beginning the electrical cautery dilator. But so basically, I love the even in such cases, mechanical dilation is much better. Yeah. Otherwise, easy bleeding or happens. Yeah.
So this is the electrocautery for you nowadays is a salvage instrument.
Yeah.
If you fail with the mechanical dilator, and in like 95% you start with a mechanical.
Yes. Mostly the 90% from the beginning is a mechanical dilator, and so less than 10% sometimes the dilating balloon first, and less than 5% or 3% electrical
cautery.
And
you know there are mechanical and balloon. So how do you choose?
So if possible, so just only mechanical dilator is much better, because that in case of the metal scent delivery system is 8.5, French are relatively big, and if the liver looks soft from the beginning, the dilating balloon. But basically, I love the mechanical dilator.
Okay. How many are on the market? So, which mechanical dilator?
So first, this is made in Japan. The EUS dilator, dedicated EUS-guided procedure dilator, very thinner and thinner tip, ultra slim tip, and from the 2.5 to 7 French, very thinner, and the minimum gap between the guide wire and the dilator.
Is it hard enough?
Very hard, very hard. So very pushability, very nice. That's why so better than dilating balloon. Yeah.
Okay.
Yeah. And so you can see another device is Dorito dilator as a mechanical dilator. This is recently developed, and like a Suhendra retriever.
It's like a screwdriver.
Yeah, modify, and long screw make it possible to penetrate even the hard bile duct.
But that's also for the difficult cases.
Very difficult cases only for me. But so recently, the junior doctor in Japan loved this devices from the beginning. But I'm worried about sometimes dangerous because not so just mechanical dilator, but screw dilator causes little bit traumatic parenchyma of liver, and if we push too long, too much strong push causes damage of the parenchyma, and in case of a pullback dilator, quick pullback also causes damage of the parenchyma. Sometimes the patient also feel pain. That's why so I realize not so safe, or not always safe.
But also one principle is probably important because exchanges are not so easy. If the guide wire is not deeply in the bowel system, exchanges are more risky.
Yeah.
So maybe you should have just one dilation and then you can use a different guide wire for guide wire manipulation, right?
Right.
So it's not easy to do 5 exchanges, but because all of a sudden you will have lost your guide wire.
Yeah.
Okay.
Okay, so we love the mechanical dilator so than the electrical cautery dilator. You can see our paper. Electrical cautery dilator causes bleeding as an adverse event, so significantly higher than cautery dilator. That's why so I love basically mechanical, just a simple dilation.
Okay. So now there is an example.
Yeah. So let's see. You not so dilated bile duct. You can see. Here.
Pretty small thing.
Yeah.
Okay.
But in our unit, very common. Like this.
Oops, you are in. Okay.
Yeah, smaller. So, as I mentioned,
rotate.
slow. Yeah.
Yeah, and rotate.
Yeah, slowly. And you can see a very nice cholangiography and the Guidewire insertion.
Looks very easy.
Yeah. And so dilator, mechanical dilator, very slim dilator, looks very easy. Very easy, and from B2, very nice direction.
Direct angular.
Yeah, angulation.
Everything is ideal almost.
Yeah, and so this direction dilator up to 7 French. That's why so 7 French, just 7 French plastic, single pigtail plastic stent can easily be placed. It takes just 10 minutes without any adverse event.
Here's the pigtail in the stomach. Okay.
Yeah. Yes, another dilation by dilating balloon. So you can see this is a very nice dilator, very thinner tip, minimum gap between the guide wire and the delivery system. So compared to the hurricane, so many years ago I lab, but so recently we labbed this kind of very ultra tapered tip dilating balloon.
So it's a combination of a dilator and a balloon. It's a balloon with which you can dilate first.
Yeah. It depends, but so in case of the very soft liver, from the beginning, soft liver, not only liver but also the bile duct wall, from the beginning, dilating this balloon make easy dilation.
Okay.
So last, we call the lethal weapon. Drill dilator, Tornas. This is a recent lethal weapon. In case of the difficult cases, maybe possible, all cases. But as I mentioned, sometimes traumatic, and it takes a long time to push and back, comparing to the simple mechanical dilator.
So you have to be careful. You have to drill it in and maybe drill it out again, and
correct.
It's only for the experienced examiner.
Exactly. The last movie here, you can see drill. It takes a long time, little by little. This is a very hard wall sickness cases, intrahepatic bile duct stone, very hard. That's why we have no choice to use these devices. Little by little, and the patient feeling a little bit pain and start moving because of just conscious sedation. And finally, up to 7 French. Little by little. And the same way, little by little pulling back. Otherwise, easily injured bile duct, but also the parenchyma over the liver. And finally, 7 French plastic stent placed.
Okay, very nice.
So last, but not least, the cautery I'd like to talk on the cautery dilator. So,
which is our salvage instrument.
Exactly. Yes. So 6 French cautery dilator is very popular in the world, but so I know the dangerous sometimes. So that's why we made 3 French electrocautery dilator. Comparing the 6 French cysto-gastro set, burn effect is minimum, very minimized. And I think if we use a cautery dilator, maybe 3 French like this, one is much better. Because so if we create the fistula using a dilator, easily after that bile leakage happen. That's why. So I worried about the bile peritonitis. One of option is bile aspiration. Bile aspiration reduce bile leakage. More than 10 cc aspiration make minimum bile peritonitis.
So this you are doing when you introduced your mechanical or whatever dilator relatively deeply into the biliary system, so you are safe.
Yeah.
Then you can extract the guide wire, and then you suck bile.
Yeah. Yeah.
Okay.
This is the video. So after guide wire insertion, you can see here the tip of the catheter. Very dilated cases here, like this here, more than 1 cm dilated. And you can see very easily aspiration of the bile duct. After that, usually no leakage through the tract.
because the duct collapses.
Yes.
Mm-hmm.
In this case, it's more than 30 cc. After that, so very dilated duct and very shrinking. It is much, much safer.
Again, take your time.
Yes.
Mm-hmm. Okay, well, at the end of this episode, what's your general approach with dilatation? So you come in with a mechanical dilator, easy case, then you exchange the guide wire?
Yes, is one of the options, change the guide wire.
And when do you do a balloon dilatation?
If we feel the very hard wall of the bile ducts, in such cases, we add the balloon dilation.
Okay, good. Yeah, that was again a very interesting episode. Takao, I thank you very much, and we are coming back with stenting. Thank you.